both represent representatives of fellowships through Fellowship Council and independent ones. So have Dr. Maggie Bosley here with us and Jeffrey Blatnick. So Dr. Blatnick, he doesn't need introductions. He specializes in minimally invasive approaches to abdominal wall and complex hernia. He is also a chief of minimally invasive surgery section and associate professor of surgery at WashU in St. Louis. And Dr. Maggie Bosley, she's an assistant professor of surgery in Division of Gastrointestinal and General Surgery in OHSU in Portland. Her current practice and research efforts seek to enhance surgical education and improve patient outcomes in hernia repair techniques and gallbladder disease. So again, this is supposed to be very interactive. So please come up with any questions. If you guys want to, actually introduce yourself in the chat, if you will, and kind of just to help us to understand how to, guide this discussion, you can just in brief. Tell us like what year are you? Are you graduated and working independently, or you're still in residency? Do you have any like particular interest within the abdominal wall, or are you applying for MIS, kind of general MIS, and you want to, get a little bit of hernia experience, a little bit of foregut bariatrics? And if you want, you can also share what's the, in general, how did you get there, and what's your pathway to the hernia world? What gets you inspired, and everybody has their own story. Maggie, do you want to go ahead and share your quick story while we are getting the questions? Like, how did you get into the hernia business?
Yeah, I actually got into the hernia business with Dr. Blatnick. I trained at WashU in his fellowship, and we closed a lot of holes while I was there. And I really wanted to become specialized in hernia abdominal wall reconstruction and was able to come out to Portland at OHSU. I'm currently joined by Sean Ornstein, and Bob Martindale for our hernia crew out here at OHSU. Um, we have pretty high volume center here, and we just had our first fellow in this past year. She's completing our first round of fellowship. I'm the program director for our group for our new fellowship, and yeah, I'm excited to be here. I think you highlighted a little bit, which we can get into a little bit more, but the hernia training landscape is a little bit different based on fellowship, whether or not you go through the match or you look for an independent fellowship. The process is a little bit different, and you can tailor what you seek out based on what you need. And I think understanding the differences between those and the nuances and what some of the fellowships sponsored by SAGES mean and requirements for that, which we can get into in a minute. But here at OHSU, our fellowship currently is an independent fellowship, so we are outside of the match, which is different than what I did as a fellow where I matched at WashU with Dr. Blatnick, but I'll let him kind of speak to that.
Yeah, I feel old when my fellows are now giving talks about fellowship and having their own fellowship. I used to think I was kind of still junior, but maybe I'm not anymore. My story, thinking back to when I was young and going through the process, I got into abdominal wall because I had a faculty mentor, Mike Rosen, which many of you, know the name. And he kind of opened my eyes to hernia repairs. And, when we first started, we were doing a lot of open abdominal wall reconstruction. We were doing external oblique releases, endoscopic component separation. A lot of people probably never seen one of those before. And it was all in the process of trying to solve the problems that we ran into with abdominal wall reconstruction. So the wound morbidity and a lot of those things you saw with external oblique releases and everything. I grew up in the era of biologic mesh for everybody. We would sew pieces of Alloderm together and try to do that and figured that we solved the world's problems. It was just going to become new fascia. And so I lived through that era as a trainee. And so for me, a lot of it was a mentorship part of the abdominal wall that I really enjoyed. And I think the variety of what we get to do is really good too. I can do a bunch of big open complex surgeries one day. Now I do a bunch of minimally invasive surgeries or robotic surgeries the next day. And so having that variety, I think is really helpful. That's part of what I liked about abdominal wall. I did my residency in Cleveland, Ohio. I actually stayed there and did my fellowship, which was mostly ab wall and a little bit of foregut. And Dr. Bosley mentioned, like, you can kind of pick and choose your fellowship by what you want to do. We did not do very much bariatrics, and I was perfectly fine with that. And so then you kind of use that skill set to go out and look for jobs afterwards. So I finished my fellowship in 2015 and then joined the faculty at WashU that summer. And, for us, our fellowship is through the match. We used to have one fellow. We've had two fellows for, let's see, 3 years now. Maggie, you were our first year with Dr. Bowsley was our first year. We had two fellows. We have two fellows. Ours is still one kind of big fellowship. So it's a mix of advanced foregut, abdominal wall, and still bariatrics. And for some people, that is intriguing. For other people, that's not what they want to do. But I do think there's value in having exposure to all those three different specialties as you go through training. And then for us, like as you get into the end of your second year or the end half of your fellowship, you can really kind of tailor it down into the areas that you want to do. So if you want to do more ab wall, we can do more ab wall. If you want to do more foregut, do more foregut. But ours is still set up where you do get exposure to all the different things. And again, I think you pick and choose what you look for. But ours is also still through the match. So you go through the match process, which, can be beneficial because you do get to see a lot of different programs. And I'll let Dr. Bosley speak specifically to how they do their match process. But, sometimes the different programs have you commit a little bit earlier. And so, the benefit of going through the match process is you get to see lots of different programs that some have different strengths and weaknesses and kind of pick and choose from there. So I think, you got to pick what you like. And then we can obviously talk about, the evaluating fellowships and that sort of stuff as time goes on.
Thank you. This is awesome. You guys both mentioned that how important it is to have a mentor, somebody who actually will drag you into and really ignite this interest. I'm not going to talk about my story because I already did last year. My catalyst was Igor Belansky, who basically get me in the field, and that's pretty much started since then. And mentorship, I think, in this field and in any surgical subspecialties, of course, is paramount. And it's really important and very helpful, I think, for those folks who are interested in OBWOL. Even if they don't have a dedicated program in their institution, they can always seek for outside electives. That's what I did. We didn't have a dedicated abdominal wall program, but you always can set up and come and see into somebody's shop and really try to get this mentorship mentees relationships early on. We do have some questions here in the not necessarily questions, but some folks are mentioning how you can really balance in this day and age the broad spectrum MIS training with subspecialization on ABWOL. And I personally, when I was applying for a match, because I didn't know until probably January that I want to do on the ABWOL, and I just realized that the field is so broad, and the learning curve for some of the complex cases that we do is really pretty substantial, right? So it's probably even comparable to some complex surgical oncology cases, perhaps. Although I'm not going to compare, Robotar with WIPO. I think those are a little bit different leagues, perhaps, but still it does require a lot of repetition to get better with that. And so if you have just very tangential exposure to the complex ABWOL to reduce, then it might not be enough for you, like, Dr. Bosley, for example, to, open her fellowship, right? And so so I hear what you're saying, that it's possible for fellows, especially if you have two fellows who can rotate and switch positions, one team, another team. That's what we have as well. That's what Prisma Health has, right? Where you can really kind of pick and choose your niche during the fellowship and really tailor your education towards your personal clinical experience. But how does it really work logistically? How are you able to teach somebody, to do gastric bypass, for example, and Robotar within 1 year?
Rosley is somebody who's lived through that. Do you want to comment first, and I'll talk a little bit about it afterwards?
Yeah, I think what we're kind of all alluding to is that there's a large breadth in what all fellowships offer, and I think you really have to dive into the details of what each fellowship brings. I know, at least from the fellowship council website, I think they still do this, but the case logs get published for each fellowship. And so if you're really interested in bariatrics, or you're really interested in foregut, or you want a broad mix, or you want a lot of hernia, you can actually look at the previous year's fellows case logs and figure out if that program aligns with what you want to do. I think if you are somebody who is not interested in foregut and bariatrics, and you just want to do ab wall, then there's certainly programs out there like ours at OHSU that are you're with the abdominal wall hernia team for 12 months out of the year. Um, I think if you want experience in other things, then there's other fellowships that can cater to that. When I was looking for fellowships, I actually initially wanted a little bit more broad experience and was looking at places that gave me a good mix, and that's what they had at WashU. Fortunately, when I came to WashU, a couple bariatric surgeons left, and I realized I hated bariatrics, so that was very convenient for me. So I got to spend a lot more time doing hernia and abdominal wall reconstruction, and I think that set me up well. But I do think you have to be conscious about how much exposure you get to if you want to just be the hernia person at an institution, and how much time and how many complex cases are you going to see and feel comfortable with. And so understanding the case logs, understanding that not all fellowship is the same, I think is really important when you move forward, and you kind of just have to understand what you want. You're not necessarily cornered either. I came to fellowship wanting a little bit of everything, and then I figured out I really wanted to just do hernia. And thankfully, my fellowship with Dr. Blatnick was flexible enough to let me kind of dive into that and get more expertise. But I think that's the important part of that, understanding hernia as a, and I'll stop in just a second, but hernia as a field has certainly exploded. And I think when we think about fellowship, we think a lot about technique and reps and number of cases. But especially in our fellowship, and I know in places around the country, when you leave our fellowship, we want you to not only understand how to do complex redo surgery, but we want you to understand how to manage fistulas. What are the differences in the meshes? How are you going to manage mesh infections? What's the science behind it? What weight are you going to use? When are you going to use this over that? And kind of understanding the field as a whole and the complications and decision making behind it is what I really want our fellows to walk away with beyond just being able to do a fast ETEP. So I think you just have to be at a place where that's going to give you the exposure that you want.
Yeah, I mean, I totally agree. I think, yeah, for everybody, it's different what you want to get out of it. Some of the secondary values of having broad training is like the job market can vary tremendously from year to year. I mean, there could be a year where there's one ab wall job and six foregut jobs, and the very next year there's six ab wall jobs and one foregut job. And so having some of that broader experience can be helpful and make you a little bit more marketable. Like I know for us, as we look for new faculty, like it's nice to have people who, have a primary area of focus, but have a secondary skill set that they can help. Cause like we still cover call for our group, so having exposure knowledge of foregut is helpful. Having exposure and knowledge is helpful. I do zero bariatric surgery and I'm perfectly, again, fine with that. But some of my practice is still foregut, and I do ab. So having a little bit of all those experiences can make you more marketable when you go looking for jobs because it can be variable, but also like as I mentioned, since a lot of practices do cross cover, like that can be helpful along the way. But not one thing's right for everybody. And so you have to look at the different places. The case mixes are really important. I think the faculty that are there is equally important. Like you want people that have experience doing the complex stuff. That's what you're going to learn from. You know, saying you did a TAR is great, and doing TARs, it's like anything in surgery. When it's easy, it's pretty easy. But, as we all know, like when it's hard, it's really, really hard. And the more tools that you can have in your tool bag when you go to do surgery is really critical. So there's a lot of personal things there. Sometimes it's the environment, it's the city, it's the call that you have to take. Do you get to function independently as an attending? Are you strictly just an apprentice where you just follow somebody around all the time and, do their orders, but yet, still learning on the job? So those are, I think, important questions to consider when you look at different fellowships is, it's far more than just whether it's hernia or foregut or bariatrics, but it's who you're working with, where you're working at, do you get that secondary exposure as an attending? And I know for us, when Dr. Bosley was there and the other, her co-fellow and the ones before, as you move through that year, you gradually get more and more autonomy where you do get some of that attending exposure. And I think that can be helpful for making that transition. But nothing's perfect in any way. It's individual for each person.
Yeah, definitely can't agree more. And even the factor of geography really takes place. For example, in OHSU, you guys have 300 miles in catchment area, right? And that's why you see all those disasters. Like there is nowhere else to go, I guess, nearby. And so that's why you still have Bob Martindale, who is taking care of fistula patients. For example, in my fellowship, we had, I mean, not here on Long Island. On Long Island, we have plenty of fistulas, but in the city, in Colombia, we saw one exact patient and we didn't do anything for them, right? Because we just didn't have set up. We didn't have wound ostomy care nursing. We didn't have nutritionist. Like the program was not set. So that's why I think that if you, as an applicant, you have, you already know where you're going to practice. So you, for example, want to go back, to your, to the state where you're from, or you have some specifics where you want to be eventually. You need to think about it where you want to get training, because the training must be very similar to that, right? So if you're going to be trained in the city, in a large city, so you're going to take the patients with all the spectrum of disease which is prevalent in that area, correct? But you might not be seeing that many folks who are morbidly obese. You're going to see, like in New York, right? Everybody's running, nobody smokes, BMI average at 25. I mean, that's very different than, I guess, in Cleveland, right? And so that's why you need to kind of even account for that factor as well. So just a quick housekeeping thing. The link that I posted, it's actually we assembled together the fellowship directory. It's probably not full. I think there are at least one additional program that I can add there. It basically has both outside the match programs, independent ones, how we call them, and those through Fellowship Council match. So it's a useful tool where you can see what's out there. There is some deadlines, emails, and so forth. So I think I guess one of the important questions that the applicant can come up with or can face is how to navigate this entire in match versus outside of match landscape, right? Because we typically outside of match programs like OHSU or ours, we are trying to align all the deadlines, all the dates with Fellowship Council, but there is some logistics involved, right? So obviously, if you're outside of match and you get an offer as an applicant, you will have to withdraw yourself from Fellowship Council match because you cannot take both offers. So that's how it works. Now, for example, what if you are outside of match applicant and you got an offer and they're not going to call you like, hey, you need to make a decision right now. They will give you, 2-3 days. So what if you, within those 2-3 days, will get a better offer? You know what I mean? And then on the other hand, how will program really manage that? So I'm kind of thinking that there is a chance that eventually, maybe over the course of years, we will come with some independent match, all the way just hernia abdominal wall match. What do you guys think about that?
Go ahead.
That's again, I'm going to sound very political in my answer, but I think there's plus and minuses to all those things. I think that, lining the schedules up is kind of hard. If you make them at the exact same time and you go through and, try to get an out of fellowship program and you're number 2 on 4 people's lists and you don't get a spot, and then all of a sudden you've missed the fellowship council match deadline, that can leave you without a spot and you're scrambling or trying to find something else afterwards. So I do think that it sort of does make sense if you're going to keep some fellowships outside of the match to probably do those early. So it gives people the opportunity to still find a program within the match. I think that just makes sense. But it's like anything when you're outside of the match. Yeah, there's some wheeling and dealing and phone calls and this and that can change stuff. And so I can understand, where that can be stressful for applicants. I think the other somewhat challenging thing to take into consideration, this happened second through fellowship time, is, people come and go. You match, a year and a half before you start your program. So, certainly in big places and academic places, people are coming and going a lot. So you kind of want to feel out what the stability of the, core faculty who you want to work with. And I think it's reasonable to ask some of those questions. They may not be able to get the truth because a lot of those things can't be disclosed, but, having an understanding of where you're going to be. But I would say that, trying to do them at the exact same time can certainly leave some people high and dry. If they're going for out of the match programs and just don't happen to get,
Yeah.
whether you have an independent match for just abdominal wall programs, I think you got to figure out what's the value in that as opposed to just rolling it all into one match. The logistics of a match is complicated, and all of the infrastructure that goes into coordinating applications and protocols and bylaws and all that sort of stuff takes a lot of work. So honestly, it may make more sense to just roll them all in together and have a true hernia, pathway within the fellowship.
Yeah, we are an independent fellowship, as I said, and we try to complete our offer to our fellow way before the deadline would be for people to submit to the match. And so that all of our applicants will know prior to the FC match. So I think if you are interested in programs that are independent, it makes a lot of sense to ask them to be clear with you about their timeline and understand what you're getting into so you can make decisions about that. I think if there's a program that's gonna hang out until the last minute on the same day as the fellowship match, that's gonna be a little bit difficult and stressful. So, yeah, just trying to get some clarity from the programs about stability and timeline, I think is a perfectly reasonable ask.
Maggie, can I ask you what makes you guys to stay outside of match? For me personally, I was planning originally to participate, truthfully, but then, as per fellowship council, you need to be a faculty and I think PD or something like that for 3 years. And at that point, I was not there yet because I pretty much just graduated from Nowitzki's fellowship, right? And so that's why it was out of equation. So we tried outside of match, and it worked out really, really well, and we liked it. It was very hassle-free process, and we were able to meet with all applicants. People were coming in for in-person visits and stuff like that, and we kind of liked it. And we said, we're just gonna stay outside of match. Did you guys consider actually joining the fellowship council, or if you
Well,
didn't, what made you not to do that?
as you've alluded to, joining the fellowship council takes time and effort, and it's not something that you just immediately join. And so we wanted to get our fellowship off the ground. And so part of that was just timing and logistics. We haven't quite decided if we're going to stay outside of the fellowship council. It may I think it's something we're still considering and joining in the future, but right now, from a logistical standpoint, similarly, it's just been easier to try to continue independent and find good people that want to be here.
All right, gotcha. So let's switch gears and really talk about try to go back when we were applicants. So what do you think makes it a really stellar applicant? Because nowadays again we see that the field is thriving and we see a lot of applicants. What's the way? How do we distinguish and try to rank the applicants? What are your factors? What do you consider the most important in the selection process, and how an applicant can make their case stronger?
Blatnick, just describe what I brought to the table, and then everybody will know that's the perfect applicant, right?
Yes. So I'm going to talk a little bit about what not to do. First, there's this fellow we had 3 years ago. No, it's tough. Like I've been a associate program director for our residency, taken over as program director for our fellowship. So like I get to read a lot of applications, specs, and I think there's a couple avenues of hurdles you have to get by. The first one's obviously the paper application. Some programs are self-included, get hundreds of applications for essentially two spots and 20 interview spots. So like you have to get through that first hurdle, and so you have to look at how you're going to put your application together. I'll give some secrets. I think personally, to me, the letters of recommendation are probably the most valuable thing that I look at, especially when you're at high levels and trying to read a lot of applications. And so making sure you choose people who can write a very, thoughtful and actually personal letter recommendation is really helpful as opposed to somebody that just copied your CV into ChatGPT and asked to make a recommendation. So have that conversation with the faculty member, like, are you comfortable writing me a letter of recommendation? Here's what's important to me, or, is that something you feel that you can do? Exposure to, the ABWAL or minimally invasive, programs is helpful. So whether that's being involved in AHS or, SAGES or the college or other things like that. So showing that you have some interest in those things along the way, as well as some, exposure to some of the MIS stuff, especially if it's in your residency, can be really, really helpful. So I think those are the big things. Obviously, ABSITE and your, scores and that sort of stuff is part of it, but that's probably not the most important thing. So I think that's the first hurdle. I don't know, Maggie, do you say about the
Yeah, I think very similarly. I say this because I just reviewed a bunch of fellowship applications a couple weeks ago, and I think it does stand out a lot when you see that the applicant takes some initiative to learn or be involved in hernia related things. If we're just talking about ABWAL recon, and I did bold each time I saw a resident had joined AHS, and so they're like thinking about hernias. It's on their horizon. I think, for better or for worse, we use research and being involved academically as some type of metric. For me, it's not necessarily that you've published 18 papers on hernia outcomes and technique, but just show that you have some initiative and that you can see a project from start to finish. And I think that stands out. So yeah, the place you are at, you might not have somebody who does a bunch of hernia and ab wall. So obviously you're not going to have as much experience. But if you're kind of seeking out opportunities, joining societies, doing a project here and there, it just shows that you have initiative. And I think that part stands out. And then just trying to have a normal conversation and interview with people. You would be surprised how many people can't hold a normal conversation. And at least in a fellowship like ours, we have 3 faculty members and you're with us for 12 months. And so if we feel like we're not going to be a good fit and get along, that's going to be a long 12 months. And so we really just want to see that you're somebody who's personable and that we can get along well with, and we know who's going to work hard.
So how do
yeah.
you guys? Go ahead, sir.
Oh, I was just gonna say, like, the in-person interview, I think, is the second hurdle, and I agree that the just having a normal conversation is important. Zoom has both been beneficial and harmful for that. It works okay in the one-on-ones. My advice that I would give in your in-person interview is don't put anything in your application you're not comfortable talking about. Every so often you'll get somebody who'll have something in their application and you ask them about it and they like just freeze up or don't actually know anything about it. So, if it makes it sound good, that's fine. But if it's not something that you've actually been involved in or can't talk about it, just leave it off your application. That'll get you into trouble when you start spiraling downhill. But I just be a normal person.
So do you both actually offer in-person interviews, or since post-pandemic state, we stay pretty much virtual?
We're
Our
done, mate.
I was just gonna say ours are completely virtual, which I think a lot of fellowships are now. I would say probably when you're doing a residency, in-person feel for the city is probably more important than your 1 year fellowship. Certainly you want to like where you live, but 365 days anywhere is 365 days anywhere. So
Yeah, we're still virtual for our fellowships. I don't envision us changing that. I think just it's more ethical or equitable for people, not having to fly and stay in a hotel and do a lot of that stuff. Our residency has switched to a hybrid. So I may eventually see us getting to a hybrid approach where you do a first round virtually and a second round in person. But at least as of right now, our fellowship is still all virtual.
Yeah, we do offer in-person option because mostly, especially if we have residents who are coming from nearby states, or they might even live nearby, in the city or on the island. In this case, there's really no reason why you cannot just drive an hour, and you don't have to. It's not a huge investment of time and resources. So some people actually really want to come, and I had residents who are coming from other states. It obviously is helpful to be near the big city. So a lot of times we'll just come to uh, to Manhattan for a weekend, and they can stop by. But in general, like you said, the 365 days, yeah, you can hold the breath for a year. That's true. But still, you have to work with the person, very closely, especially in you if you are, the main faculty for the program. How do you pass that vibe check? And in general, how does it work for virtual? Because it's kind of sometimes a little bit difficult to read each other. Are there any advices you can give?
Yeah, the virtual, like the feel of the program is hard to get. Like one-on-one interviews, I think virtually actually work pretty good. Like you can talk to somebody and do that. But you do miss a little bit on like how people interact, how the faculty interact with each other, how the current fellows interact with each other. So that can be a little bit hard. Group Zoom meetings is hard. Everybody kind of like talks at the same time and then stops talking at the same time because you overlap. And so it can be a little bit challenging. I think your best resource for that is the current fellows. Talk to the fellows that are there. Like you should have access to them during your interview. I know our fellows are involved in that. And so I think that can give you a good aspect of what things are. You don't have to do that in front of the whole group, even if you reach out to them kind of independently or have one-on-one time with them to understand kind of what's been their experience with the current faculty, I think can be really helpful.
Sorry, I forgot to unmute myself. Um, when it comes to international applicants, or not necessarily international, but graduates from not American medical schools, Caribbean schools, international schools, um, do you guys have any restrictions at your institution? What advice can you give to IMGs? For example, I am IMG, and the only reason why I actually started to look for fellowship is because I got green card. During my residency, I wouldn't even think about it. I would go and work in the back country for a while until I get green card, because I know that's logistically very difficult for a lot of programs to sponsor, even J visa.
Yeah, I know at OHSU at least we can't sponsor any J1 visas, and so we try to make that very clear on our website. And when we have people interview, if they say that when they apply, that they have a visa, we have to, tell them, unfortunately, we can't interview them. So if you do have a visa, I think you have to just do a lot of homework on the front end to make sure that that program can support you.
Yeah, for us, like we will accept J1 visa applicants, but the problem is since our fellows have attending privileges and can do attending cases, people on J1 visas can't bill, so they're unable to collect revenue there. And so when you think about on our side, the economics of fellows and all that sort of stuff, like it can be challenging. So I agree with what Dr. Bosley said. I think you just have to be, very thorough in your research, reach out to programs ahead of time, send them an email and say, here's my situation, would you consider me as a candidate? And it does take more legwork up front, but I think it will be helpful in the long term.
Got it. I think a couple of months ago, Ben Fung, who was a co-chair of NHS Resident Fellow Committee, he recorded a funny video, one day in the life of a AWR fellow. So, it was obviously a very, very busy day, I guess, 2 days, but how can a, a fellow in your program, for example, make it most of that 1 year? So just, without obviously any calling names, but like what can you do to really get as most as you can from the program, from all aspects, clinical research, partnership, any
So
advices you can?
Yeah, I think again, you have to have an understanding of what you're going into that fellowship for. If you're very much interested in research, the clinical fellows, you have to kind of pick and choose which one you go to. I think a lot of people go into a year of clinical fellowship to really hone that technical skills and whatnot. I would say it may sound kind of counterintuitive, but go to as much clinic as you can. Most of us as surgeons don't like clinic, but that's where the decisions are actually made, more so than the decisions of who's getting surgery, but the decisions of who's not getting surgery. And that can be hard. Like it's very easy to say, like, yes, I'm going to fix your inguinal hernia. It's much harder to say no, like you're not a candidate for whatever reason and have that conversation with patients. So my advice, obviously, to get the most out of that time is know what you want to get out of it and kind of pick a fellowship that's going to address that. have an understanding of what the program's strengths are and take advantage of that. Go to clinic. I think that again is really, really helpful. And then when you get down to the nitty gritty of like individual cases and whatnot, like have a plan. I know Dr. Botley would come to surgery with her little notebook and like wrote down all the things, took notes afterwards, and like we'd sit there and brainstorm about how to do stuff better and like try to solve problems. And by the end of the year, like it was much more of a collaborative effort to do cases than it was like, hey, let me teach you how to do stuff. And I'll speak from a faculty member too, like that's very enjoyable. So as you go through, like be engaged, record your videos, go back and watch them, because in the heat of the moment, you don't necessarily appreciate where your opportunities are. But by taking that extra bit of time, I think can be really beneficial. They're kind of the high level things.
Yeah, I think the maybe the first half, or I don't know what portion of the first part of your fellowship, you're probably very focused on learning the technique and trying to master, if you can master the technique in your fellowship. But really you have to, I think, change your thinking towards the end of your fellowship, or maybe throughout, that you are transitioning to do this on your own. And so often when I'm in the OR, I'm prompting my fellow, like, what suture do you want them to start getting? What are you gonna, what supplies do we need? What's next? And like, instead of me saying like, do this, do this, do this, trying to get them to think about how they're going to progress the case and how they're going to progress it efficiently and get everything that they need and run the room. And that type of learning needs to be really emphasized, I think, to run an efficient practice when you get started. And you just don't even realize all the things that your attendings are doing in the background, and their pick list, and they're going to the OR, and they're making sure things are set up, and they've been haggling insurance or whatever on the back end, and you're not seeing all the stuff that happens behind the scenes. So trying to get an exposure to that is really important. When I first came to OHSU, Oregon Medicaid is very different than what we were dealing with when I was a fellow in Missouri. And so there's certain things that get cases approved and certain things that don't, and certain ways to bill and certain ways to run your clinic and follow patients up and communicate with other providers. And so I'm very intentional about trying to expose my fellow to all of those elements. If the faculty you're working with is doesn't have that at the forefront of their mind, you need to try to seek those things out, because you're in fellowship to learn the technique, but you're also there to learn the decision making, learn how to run an efficient clinic, learn how to get somebody from the clinic to the OR, et cetera, et cetera. And there's a big learning curve with all of that. And it certainly won't stop the day you finish fellowship. But if you can give yourself a head start by trying to learn all of those things, it's going to help you a lot.
Yeah, that's awesome. I cannot agree more that, how they say, first 5 years you learn how to operate, right? And then when not to operate. We kind of found a solution in our program. So fellow doesn't spend hours seeing straightforward cases in the clinic. What we do instead is we handpick complex, difficult cases, and once a month or sometimes every 2 months we have like kind of webinar where we discuss all those, like hernia rounds more or less, where we discuss those handpicked cases where the really difficult decision-making process, because I would rather the fellow to go and scrub and do some cases with my partners than sit in the clinic and see straightforward post-ops with no complications, or some straightforward same day cases. I have a question here in the audience. What's your take, and what can you advise for folks who are already in the practice? For example, we do have some applicants coming from military who are right now staff surgeons, in military centers, and they, their practice is seeking for additional training in EMBOL because they, substantially lacking that, or trauma surgeons, and like, what advices can you give for those folks? Because obviously, probably 90% of our applicants are PGY4s, but what about those who are already in the practice and been out for a couple of years?
I will say that our fellow starting in the fall is currently a bariatric surgeon who is going to be joining us. She's 1 year into practice. And she realized that she wants more exposure to AWR, and she wants to make that a part of her practice and be able to basically offer the full gamut to patients of weight loss before their hernia repair, and then repair their hernia. I can't speak for everybody, but we can appreciate when somebody who is mature enough to be out in their practice and then want to still pursue additional training. And I think that takes a level of maturity to want to come back and be a trainee. And so we don't look down upon that at all. It's actually a plus, I think. But I think you also, if you want to go do that, you have to be prepared and have the mentality that you are going to come back and be a trainee, right? Our fellow in the fall has been running her own practice, and now when she joins, she's going to have to defer to whatever I want to do. And so, being able to make that transition back, I think you have to be prepared for that mentally, but it doesn't preclude you from being able to do a fellowship later.
Yeah, I agree. I think that having the same rationale why you want to do it, what you're looking to get out of it, what you're long, which is what we ask PGY4s as well, I think is really important. But it is certainly, it does require that it can be a mental change for the applicant to go back and suddenly be a trainee again.
Alrighty. When it comes to job market, right? So we know that over the last couple of years, we did see substantial decline in bariatric jobs, obviously with GLPs. For hernia, I remember when I was looking for a job, there was really nothing much. There were like one or two postings, and I was using Google Aggregator, I was using Sage's job board, AHS. Google Aggregator actually was, in my opinion, surprisingly the most useful because somehow it really gets the postings from every single website, including LinkedIn, including all the societies, job boards, and it was pretty useful. You can even make a like a notification by some keywords, and it's just going to come to your email like every week if there's anything new, any new postings. But I mean, we all know that in surgery, probably, I don't know, 60-70% of jobs are still distributed by word of mouth kind of thing, right? So what can you comment on how things are in hernia world?
Again, I think it's varied from year to year. Like, I've been doing this for 10 years now and trying to help fellows find jobs, and you just see a tremendous variability in where things are. I think what you mentioned is great. Sage's college has a job board, using some of those web searches. I know a lot of things are on LinkedIn now. So you kind of have to be open to that. Talk to your faculty mentors. They a lot of times will know people. If you have a region that you want to be in, if you want to be in, the East Coast or West Coast, sometimes you just got to start shooting out emails and say like, hey, this is who I am. Here's my CV. This is what I'm looking for. Are you looking to hire anybody, or do you know anybody that is? Um, Surprised what will come back from those sorts of things. So I think sometimes it's easy, sometimes it's really hard, and got to kind of think about what's important to you. Like, is the region more important than the job mix? Is the location less important than academics? Do you want to be in private practice? So you kind of have to have a list of like what's important for you when you start looking for jobs, and how important those different things are. Some are go, no go. And so when you start putting that stuff together, we'll make it a little bit easier.
Yeah, and I think you have to really hone in on what you want your practice to look like. I think, at least my perception is that finding a place where you're only doing hernia and abdominal wall, and that's your whole practice, and that's what you take call for is pretty rare, unless you're going to be at a really big academic center, and those jobs are not just like plentiful. I know our current fellow is interested in doing a mix of general surgery at a more community sized hospital and kind of being the hernia referral person for the group that she's with. And she's finding some options for that, but certainly, I think when she was first in fellowship, she was thinking she was just going to do hernia when she finished, and slowly over time she's realized that, you know, to be in a certain setting, you're probably going to have a mix in your practice. And so understanding that and kind of seeking that out, and then you may be if you're interested in that, joining a general surgery group and telling them and marketing yourself as having this expertise that you can bring to the group, and they might not have even realized that they needed that for their area or group, and you can really create a niche for yourself there. So I would just kind of open your mind to different opportunities, but really hone in on what you want to do and where you want to be. And is it academic? Is it hybrid? Is it truly private practice? And I think that will help give you some direction.
In
Yeah, I think
terms, sorry,
go
sorry,
ahead,
Eric.
go ahead, Nikki.
In terms of choosing a fellowship, do you feel like uh, uh, applicants should look for programs that do match those things that they're very dedicated to, say their um, academic setting or even geographic setting? Do you feel like it's important for applicants to go after fellowships in that same area?
I think if you say, I know I really want to go back and work at a community hospital and do broad-based general surgery, but want to have some exposure to abdominal wall, like, yeah, I think you use that to kind of look at some of the different fellowships that have that opportunity, as opposed to going to someplace where all you do is like complex TARS day. So I think if you know strongly that like I want to go back here or this is the environment I want to work in, looking for programs that have similar aspects I think can be helpful. I don't know if the geographic region is quite as restricting, although certainly like being in an area can make it a little bit easier and gives you what's available in that area. But yeah, I think it can be helpful if you know already where you want to be from a program or a practice standpoint to look for something that will support that.
I think it's pretty important also for um, a new fellow to start looking for the job quite early. So if you're going to start looking in January, you are late in the game because, for most places, if you're looking at the academic settings, for example, the fiscal year starts in July. So all the hiring plans are already, made, and the budget, for that new position is already set. So most of the places know that they will be hiring really almost a year ahead. I think this is what the reality is then. So honestly, just start really early on and you know use all your resources. What Dr. Blatnick mentioned, that it's actually very much acceptable to write almost cold emails, or really trying to you know through your acquaintances get to the person who potentially is hiring this year. That's not unreasonable, because a lot of times all those job posts, if people already have an internal applicant or somebody who potentially will be joining, and they just post it, to conduct a nationwide search. So I think it's to be proactive is very important, and this is not like residency, right? So it's in residency you cannot write cold emails to the programs because you're going to get just annoyance, and that will not be received well. But if you are, looking for the job and you are being proactive, I think it's completely reasonable. Alrighty, so folks, attendees, I don't see any other questions. So
There is one other question in the I found another tab. Someone asked, uh, do we feel like the hernia center designation that is a new thing in AHS that we're proponents of, do we feel like that's important to seek out programs that have that? Is that uh, is that important to have now, or important to be within the pilot program for that?
I think we don't have it completely defined yet. This is newly coming out of AHS, and I think there's still a little bit of controversy about what this means and how to best use it. And so I think when you're looking for a fellowship, that's probably not the end all be all. You should make sure that it has the volume you want and the expertise you want and the faculty you want. And if it has a hernia designation, that's a bonus. But probably all of the places that do enough volume to be able to facilitate a fellowship would be able to meet criteria that for hernia center of excellence. And so I would focus on the other aspects and let that fall into place.
yeah, totally. Also keep in mind that the AHS practice-specific designation, as Maggie said, is a relatively new thing. There are also some other, societies, I guess, you can get the hernia center of excellence, you know, but this is actually something that very easy to get, but it does require you to pay a lot of money for that credentialing, body. And this is just pure marketing. It's just to distinguish your practice from other practices. But definitely don't look at it when you are applying for fellowship, because I know a lot of hernia center of excellence where you wouldn't want to go to get trained.
Yeah, and the Fellowship Council recently added their own hernia abdominal wall kind of designation in addition to all the other ones that has, went through a lot of vetting through all the different major societies. We're kind of part of that process to decide like what case requirements. So, it's to be determined what all those things actually mean and will change as you go looking for jobs. And at this point, I'm not aware of any institution that's going to require those sorts of certifications, kind of like bariatrics does necessarily. So I agree. I think looking at the individual case logs, what kind of volume they do, ask those kind of questions as you go through the interview process is just as beneficial because you can call yourself whatever you want.
Yeah, and then just once again, feel free to look at that fellowship director which we put together on AHS website. It will be updated once we get more programs. Another thing how prospective applicant can get involved, definitely, we all get in emails from AHS, and there is a resident and fellow committee of which Nikki Saledis is a chair of this year. And so if you want to be involved, you certainly can and should do that. And if you do that, that's by itself speaks for itself, right? You are just now made yourself a hernia enthusiast, right? Because actions, that's what matters. You can talk whatever you want in your personal statement, but if there is nothing to support, your words, that just remains words. So you need to show something for your, prospective employer. And another thing you can also do is you can come to HS and join our Hernia Jeopardy. So that's a lot of fun, a lot of faculty actually, because it's just really fun thing. And obviously it's not a Nobel Prize, but if you if you do well on the Jeopardy, I think by itself it again distinguish you from many other applicants. That's my guess. Nikki, anything else to add? What do you think?
No, I can post my contact info if anyone wants to get involved. I think that um, hernia is a very small world, and so any way that you can get more information, network a little bit, make new friends, it'll help you not just with fellowship, but beyond. And yes, anything I can do to help anybody.
All right, very nice, short and sweet. Um, Thank you very much, Dr. Boston and Dr. Blatnick, for taking time and joining us today, and Nikki as well, and Barb. So I guess we can wrap it up if there are no other questions.
And thanks for having us. This was great. It's always fun to talk about these sorts of things, and certainly look forward to.
Awesome.
Thanks,
Thank you,
everybody.
everyone.